I'd like to welcome Dr. Esponda. Dr. Esponda is a vascular surgeon down at Sanger Health in Charlotte, North Carolina. Thank you for agreeing to do this podcast.
My pleasure, Anil. How you doing, sir?
Doing well, thank you. So we wanted to start to frame some of their talk for the VOU voices with starting to talk about eyeglasses. Can you tell us what you've learned about eyeglasses along
So,
the way?
so when it comes to veins, right? I like to frame the use of eyeglasses in the perspective of venous insufficiency. I tell my patients that um, if they wear eyeglasses or not, and what are their expectancies of using eyeglasses. I tell them that, of course, once you start using eyeglasses, you put them on the nightstand at night and they stop working. As a matter of fact, nobody pretends to be cured from eye problems after the use of eyeglasses as well. Moreover, people do expect that as time goes by, they'll need a change in prescription because eye problems continue to be progressive over time. And with this story that I give patients, then I parallel into, so what are your thoughts of compression stockings? Because really, they act pretty much the same way as eyeglasses. As a matter of fact, when you put your stockings in the drawer, they're no longer working for you. And it would be an awful thing to think that compression stockings, once you remove them, you should continue to have the benefit and the support of it. And that's the way I guess I sell my patients into the idea of wearing compression stockings because it reframes their expectations about that tool in management.
So, how do you use them to help yourself diagnose patients with venous insufficiency as compared to the differential? Because I think there's still some pushback that I get from patients when I ask them to, here's a prescription, start wearing these stockings.
Yes, I mean, half of the job most often it's done through my referral base, as my referral base basically tells me I have a patient here with this myriad of symptoms. Would you please evaluate them? And of course, we do the ultrasound, and I already have half of a story, right, from what the primary care physician would tell me and what venous insufficiency I would have or not. But truth be told, the way I approach this is by asking the patient, well, what brings you here? What can I do for you today? So often it happens that what patients tell me is, oh, my veins. And then I go like, well, I see some veins. Is there a problem with them? And this is a very particular question because sometimes it happens that patient has an ache, some sort of symptoms. Then they immediately look at the leg, and what happens is they see a vein and then blame the symptom because they see a vein. And often what happens is that, as you already know this, vein symptoms are very not specific of anything in particular. Um, we are used to hear heaviness, achiness, swelling, throbbing sensation, itching. That's what is probably usual. But some patients will come here with night cramps, restless legs, tingling sensation, burning sensation. And you could have all of them or some of them and have venous insufficiency. And it's likely that you will also have maybe some other disease process, right? What I tell my patients is, well, you not only have veins, you have muscles, you have bones, you have nerves. And this actually allows me to reframe symptoms to a particular disease etiology, so to speak.
So if the patient's venous or their symptoms gets better with stockings, then you feel more secure that doing an intervention would help because it's maybe coming from venous insufficiency.
So the end point of the consult, I reframe it as not to end up in an intervention, to tell you the truth. The way I reframed it is because the second tool in my arsenal after the patient comes in really is I gave them a quality of life measure tool. Okay. That immediately allowed the patient to think of their symptoms and reframe them in terms of how they impact their quality of life. And then what happens is that I need to understand this further, even though that you've described a certain set of symptoms and how they impact your quality of life. I'm not too sure that what symptoms you describe to me are entirely venous, right? Because they are so non-specific. So, and then making a parallel to this, I even tell my patients, look, one of the worst things that I can do here, other than cause you harm, is to do a procedure and you come back to me and tell me I feel the same way. That would have been awful because we missed the diagnosis entirely. So I put the onus on them, so to speak, and let's use this management tool. Okay. And then I say compression stockings. Immediately I see the pushback. Oh, they're too warm. Oh, they're difficult to put on. Oh, they're too uncomfortable. But what if, okay, you feel better? And then it's like, how come? Well, you understand that you have lived probably with venous insufficiency for your whole life. And sometimes people do forget what it's like to feel well. As a matter of fact, every single patient of mine, once they use compression stockings intentionally, they admit to feeling different. And really, that's all I need from them because that will reframe expectations from treatment. I tell them, look, what compression stockings don't do for you, a procedure will not do either, right? So, in the list of symptoms that you may check for me, among the 6 or 5 symptoms that you complain about, let's say that you feel that 3 of them have diminished in frequency and intensity from the use of compression stockings. I believe that's a win. Well, because we know that the act of compression, maybe it's optimizing venous return to the heart. And by the end of the day, you no longer feel as miserable as you did before. And well, so it happens that what 2 other symptoms that you acknowledge might have nothing to do with venous insufficiency. And that's where I go into, do you suffer from back problems? Are you diabetic? Issues with peripheral neuropathy, nerve root compression, and so on.
But I want to shift gears a little bit, not only in terms of diagnosis and setting expectations, but if you have a patient that has a DVT, how do you, after you've made the diagnosis with an acute DVT, how do you how do you frame the use of stockings in a patient with an acute DVT?
Well, usually most patients that have a proximal or a very symptomatic DVT usually get swelling. And that's probably the main purpose of it. Um, as you are probably aware, um, there could be problems along the line of somebody that have a deep vein thrombosis, such as post-thrombotic syndrome, right? Um, we wish that the use of compression stockings would, in some way, um, decrease the incidence of post-thrombotic syndrome, but it appears that that might not be necessarily the case. So it really rests on the use of anticoagulants, as it should be the management of compression, of a deep vein thrombosis, and the compression stocking for support in terms of symptom management. I tell the patients that neither of those two elements, the medication or the compression, will dissolve the clot itself. This is more to increase blood flow through your use of optimal venous return to the heart through compression, and then allowing the clot to dissolve it on its own, meanwhile preventing from further buildup with the use of anticoagulants.
Okay, great. Because I am finding some patients who have a swollen leg after DVT, and they come back to the office after their acute event, and they've read the SOX trial, and or at least something about the SOX trial, and some of them are educated and uh, Google or use PubMed or whatever, um, and I get pushback. Um, and that can be challenging in some of these patients when I do feel that you have a swollen leg, you really do need to help. You do need to, these may help you.
Yeah, it's interesting. Depending on how you read about the SOX trial, right? It's not that compression stockings are useless. It's not that. It's just that the proof from prevent further progression into post-thrombotic syndrome, it's well not as firm as we would like, right? But the tool as a as compression stocking is, right, as providing compression to a leg that's likely swollen from the aftermath of a deep vein thrombosis or from chronic venous insufficiency, it is a very valid use for the tool as it is.
So, what tools do you use to help the patients who say they're too tight, they're too hard to put on, they're too hot? How, besides saying, let's try it, it might actually help your symptoms, and it may actually help us determine the etiology of your symptoms. How do you get around some of those? How do you explain to the patients we should give it a try?
So let me use you for example to reframe this. Okay, so Anno, what if you will feel better after using compression? Just use it a day or two. Okay, I don't mean for you to use this for 3 months in a row, as in some institutions pretend, right? I need you to understand your own disease process, okay? And if you've lived for so long with chronic venous insufficiency, and you may have this ropey veins, and you may have this swollen leg or this discolored thing, skin, here's the thing. If I put you 20 years back into this leg, you would be horrified because it happened in an overnight setting, right? But as time went by, you really just got used to yourself. Okay. You go home, you're tired after a long days of work, you go to sleep, and you wake up refreshed. And that's your baseline as you accept it, right? But what if I can give you a little bit of a spring to your walk with the use of compression stockings? Now in the evening, you get to go home and now you feel a little bit of energy to play with your grandkids or maybe go out for dinner with your wife because you feel better about something that you were not even aware. Moreover, I even tell them that sometimes, even when they use compression stockings and they remove them just prior to go to bed, and they immediately feel uncomfortable and they can notice how uncomfortable it could be, it's not that the compression stocking is harming them. It really is the contrast between support and not having anything, akin to wearing eyeglasses, right? You don't blame eyeglasses for not seeing, immediately after removing them, right? You recognize the fact that you're no longer using eyeglasses, and as a result, you don't see that as much, right? But now, because you're hyper aware of what is it that compression stockings do for you, now you recognize symptoms. And that's what I want to bring you back to the office, okay? Because at that moment in time, we'll basically balance the potential for further improvement with an intervention, for example. Or maybe you should just wear compression stockings and have different colors for every situation. The way I measure success here in the clinic is when a patient really, after wearing compression stockings, comes back and tells me, I have them in different colors now because I like them. I don't need you. Well, I'm glad I'm here. And then I go, I pat myself in the back. We did a good job. We improved your quality of life. And as a matter of fact, this is something that is very objectively measured. I give the same instrument of quality of life before and after compression. And those that respond best, you could see the shift in symptoms. For example, if I'm going to speak about it, it's like the veins symptoms. Those first nine elements where patients check either daily, sometimes a week, never, you see the shift from an in frequency from symptoms, and some of them they even disappear altogether. So you see, improvement in quality of life is what I'm pursuing, because maybe this is the patient that's actually wearing compression. I mean, that's actually wearing using eyeglasses, and then I asked them, so why haven't you had LASIK to your eyes yet? Right? Because it could go both ways. You feel well and you feel functional with your eyeglasses, and you don't feel that having a more definite treatment pathway is the right path for you. Therefore, you're wearing eyeglasses. Imagine how crazy it would be that you go to the ophthalmologist and immediately after they diagnose you with some eye trouble, they say, yeah, let's do surgery tomorrow. That's the right pathway for you. No, absolutely not. So now, for example, if you believe that because the benefit of compression stockings, okay, is so palpable and evident for you, and you want a better baseline to start with, well, maybe we can consider an intervention, right? And then we go on into um, how advanced their disease process may be, edema, skin discoloration, and so on. That's how I sell the whole process, I guess.
So after, when you talk about the intervention, patients I find also ask, well, I'm going to get this procedure done. Do I need to use the stockings afterwards? And sometimes there's some hesitancy because the stockings have helped them. And sometimes they're like, I want to do the procedure so I can get rid of the stockings because I'm uncomfortable. So, how do you approach this issue post procedure in terms of the usage of stockings with a patient who's considering whether or not to have an intervention?
So we need to then reframe again, right? The expectations of a patient after the use of compression stockings and why they should expect from a procedure itself. Okay. Sadly, we are not curing them. As a matter of fact, our current treatment methods are quite barbaric. Okay. Decades ago, it was through a stripping of the vein, yanking it out, as I tell the patients. Otherwise, currently I'm using a hot poker, putting it inside the vein and burning the vein back, right? And I put it that way so patients understand that really all I'm doing is I am rendering the vein unusual, and the body will just absorb it in time, akin to what we might have done decades ago. So we're not fixing a vein. We're really, in a sense, amputating a vein. And why I say amputating? Because, some patients may have, of course, venous insufficiency, but may not have a disease process that warrants an intervention. And I tell them, look, I see your symptoms. I see how is it that compression stockings help you. I'm looking at the ultrasound, and you have only little segments here and there of reflux. Understand that this is an amputation. And if you had an ingrown nail in your thumb, and I said, well, why don't we just cut the arm so you no longer have an ingrown nail? That wouldn't make any sense, right? So let's do it differently. Let's continue using the compression stockings, and we'll be friends for a long time because this is a disease process that is chronic. And in time, you will let me know how is it that you're doing, how the limiting factors of your daily activities and so on. And then we'll negotiate about it. You'll have to convince me to actually do this procedure for you getting the maximum benefit from it.
I want to thank you for looking over some of these topics about a topic that's crucially important. The use of compression is the bedrock for not only for helping our patients in terms of diagnosis and treatment, but also in terms of for us to help with diagnosis and treatment. So the data worldwide has been overwhelming. We have very little level 1A data worldwide in surgery, and this is clearly some of the data that I think has been very important in terms of our field with venous insufficiency. So thank you so much in terms of delving into this. I think these are items that we deal with every day, and I think you've helped really shed some light on some of your experiences with compression stockings and can help the rest of us. Thank you.
Oh, my my pleasure, sir. Thank you so much for having me.